Everyone. So we start with the first session, and I'll be calling the chairpersons, Dr. Eric Botham. Dr. Love is here with me. Dr. Saurabh Jain. So as I entered the hall, I said it's a big hall for the small eyes. So I hope we have large number of audience. So, should we start with the first talk, or so we have Dr. Anuradha, who is a localite here of Kolkata. She'll be talking about how to refract a child and prescribe glasses. So that's a very important thing when we deal a child for pediatric opthal. Dr. Anuradha, over to you.
Thank you, sir, for this opportunity. And please give the slides on the main screen. Thank you. So I would be talking on the most important topic which we face every day in our pediatric clinics and in our general clinic. So I would be going through some pertinent points. I have no financial interest, and points to ponder is how to make the child comfortable, how to do the cycloplegia and the dilated autorefraction, whether it is good or not, how to do a good retinoscopy, post-mydriatic test, and optimal correction, whether should be undercorrect, overcorrect, and some special situations. So how to make a child comfortable? The first and foremost thing is we should have a smiling face and child-friendly environment. Allow the mother to take the child in the lap, talk to the parents for first few minutes, use some cartoons or puppets, make friends with the child before going in and doing the retinoscopy or putting the drops. In infants, maybe sleeping child is very helpful. Cycloplegia, we know that cyclopentolate, we need to know some side effects before putting those drops routinely into the eye, like cyclopentolate may have acute psychosis in some cases. Atropine has to be avoided in history of Down syndrome or convulsions. Humatropine can be given in most of the cases, and tropicamide and humatropine, in these cases, we should know for allergic reactions. Dilated autorefraction. This is only giving us an estimate. It helps to tell the parents, okay, look, your child has some power, but it doesn't give you the actual power. The actual power should come from a retinoscopy. The undilated AR should never be done because it is fallacious, because child has a very strong accommodation and it will give us a false high values. How to do a good retinoscopy? It should be a dark room, calm child. Distance, you have to give an interesting target, maybe a cartoon or some videos. Sleeping infant, again, is a helpful thing. Well-dilated pupil with good cycloplegia. Wait for 40-45 minutes to get a good cycloplegia. And a proper documentation of the cycloplegic retinoscopy with working distance should be noted. Many a times what happens is when it is a small child, you tend to go near, so the working distance reduces. That should be kept in mind. Post-mydriatic test, it is required when you are giving the glasses for the first time. For children, when you do a fine-tuning of your with a subjective refraction. For the hyperopes, if the child is not symptomatic, then you would like to give a minimum power if required. Reaching the sweet point, so we have to give the minus power, which gives the best refraction, best visual acuity, and doesn't compromise on the, doesn't overcorrect the patient. In cases of accommodative esotropia, atropine is our final point, and in amblyopia, we have to think. So there is a general rule for isometropia. You have to correct the child if the child is less than 1 year and the myopia is more than -5 diopter. As the child grows up, your threshold also reduces. For hyperope, again, a child more than 6 diopter has to be corrected if the patient is asymptomatic. And as the child grows up, you have to correct accordingly. Hyperopia with esotropia. Again, our threshold will reduce for giving glasses. Once the child is less than 1 year, 2.5 or more has to be corrected. 1 to 2 years, give +2 diopter, or 2 to 3 years, you start correcting once the child is more than 1.5 diopter. Astigmatism, again, 2.5 or more has to be corrected. If the child is 4 years and above, then you have to correct if it is more than 1.5 diopter, or if the patient is symptomatic. When you are anisometropic, then you have to correct earlier. So it is the threshold reduces more than -4 diopter in less than 1 year. In hyperope, it is more than 2.5 diopter, and in astigmatism, again, it is more than 2.5 diopter. So we will go through some situations. I would like to know their answer, but I think there is no mic for the audience. The child has come for a routine examination at the age of 3 years, and the Lia symbol shows that both the eyes are 3 by 4.8. The retinoscopy shows a working power of 3 diopter and 3.5 diopter. What would you like to do? So like most of the patients, you would just watch the patient because the patient is asymptomatic, he doesn't have esotropia, and the vision is fairly good. Situation 2, same with asthenopic symptoms. So the age is 5 years and the child has started formal schooling. Would you like to comment, sir? It comes to around, in Snellen's acuity, it will come as 612 or 6 by 7.5.
See, personally, I would give them a low hypermetropic correction, maybe +1 in the right and +1.5 in the left.
Minimum that
like
we can
exactly.
Take up. Okay. Sir, any other views?
I think whenever, it's more than 2 or 3, I would just suggest the parents that this is that kind of reflective error where the child can develop intermittent esotropia or an accommodative esotropia. So maybe I would be a little on the side of, counseling the parents that the child may need glasses, and if they discover any kind of intermittent esotropia, then we should prescribe the glasses. Because 2 to 6, you have this issue of developing intermittent esotropia.
Yes. So going to the next situation, it is a routine examination. The child age is 5 years. The right eye, the vision is 6 by 12. The left eye is 6 by 6. When we do retinoscopy, there is +5.5 diopter spherical with a -2 cylinder in the right eye, and the left eye has +5 diopter with a -0.75 cylinder. So going from the retinoscopy, the astigmatism seems to be the problem. So giving the minimum plus with a full correction for astigmatism would be the way forward with exercises. Situation 4, sudden squinting. We all have these patients in our clinic, and dilated retinoscopy with CTC shows a 3 diopter. So what first you need to do is a atropine refraction and see, because this +3 may be 5 or 6, and you have to correct the whole. And once squinting is for near, even after correcting for distance, do you give it on the first go or do you give bifocals later? That would be my question.
I think we can observe with the first time by giving a monofocal, and then next visit, if it is persisting, then go for a bifocal.
Yeah, I think the same here. Like, just give him a chance with the monofocals, because bifocals, if you give, sometimes they're difficult to wean off and they are awkward for a child,
And the child doesn't like.
Child may still agree, but the parents don't like it.
In follow-up, patients like this, so you give them the glasses, the hyperopic glasses, and they're straight at distance, you're implying,
yes.
but they're still crossing at near.
Near.
At a follow-up visit, some people will trial them with +3 glasses
Yes.
in the office to determine what happens to that near angle. And if you add the additional 3 over the top of their glasses, we may want to know if their stereopsis gets better, what the alignment angle at near gets better. But even in those situations, it's not clear whether the best choice is to give them bifocals or not. And there is some evidence in the research in articles fairly recently that have suggested if you look at those two groups, even though they look straighter at distance and near in glasses with a bifocal, that there is some evidence that would suggest that giving them a bifocal doesn't always help the outcome. And some people question whether it could take away strabismus surgery results long term. And so I think it's an area that we still are studying. Either option I think is reasonable, but for me, the more that I see the addition of a bifocal in the office later helping their near alignment or stereopsis, the more I would add in the bifocal. And the less I see it helping over the top of the +3s, the more I might counsel family to watch it. That's my approach.
Yeah, I think that's really key, and what Dr. Bothon has said, if you're saying this is a convergence excess esotropia, true convergence excess, you have to show in the office that with the +3 or whatever, you make them straight for near, because if you don't, there's no point. There really is no. You have to give them stereo for near, and then you prescribe an executive style, pupil bisecting bifocal, and then, yeah, they do very well.
Thank you, sir. So other thing which we are always encountering in our clinic is a progressive myopia with more than 0.5 diopter change in a year for a 5-year-old child. So what to do next? So we do have myopia control glasses and atropine for us. And the last one, recent history of blurring of vision, 13-year-old child with very high astigmatism, irregular axis. So we should rule out keratoconus. Thank you.
Thank you. And then we'll go to the next speaker, which is Dr. Nihal Adil Hassan. And she will be speaking on imaging in pediatric age group.
Can you ask a question to the previous speaker?
Yeah.
Yes. So I just wanted to know, in these young children, you have hyperopic errors, you have myopic errors, and you have astigmatism along with it. So when would it be a good choice to convert a part of the cylinder into a spherical equivalent? Because what happens in these young children, if you have high astigmatism, diagnosis and optical management, because it's just not a white reflex, it can be the harbinger of serious diseases as well. So the first thing when the child comes to you, obviously, is the parents who are going to be talking. So a detailed history is very important, because a detailed history can take you to the etiology, and also one can predict the challenges in the management which are going to come up. So the onset of symptoms, as you would do in any case, when the child comes to you, there's diminution of vision. Usually, the parents would say leukocoria in a very young child, but in older children, probably when the child is unable to read, when he goes to school, that's the time they would present. So it could present towards a congenital or an acquired pathology. It could be a developmental cataract as well. The duration of symptoms is very important because they are predictors of diagnosis and also the etiology. Antenatal history, again, very important. Any history of fever or rash in the mother to rule out any torch infections. History of prematurity, again, any treatment in the form of laser intravitreal injection, which could lead to, again, a cataract formation because of the injections or maybe otherwise. Any drug intake, any metabolic disorders, any history of delayed cry, that's very important. So all these things have to be taken when you're dealing with a child with cataract, because if you're going to operate, a lot of things would depend upon, the visual outcome would depend upon what the child has been through. So cataracts are sometimes associated with systemic disorders, and history of developmental delay, along with any treatment taken, check the milestones of the child. So these are very important things when you're dealing with a child who has come to you for cataract surgery. So the evaluation goes, obviously, you as an ophthalmologist would do your ophthalmology examination assessment first when the child presents to you. The ancillary things what you can do are ultrasound, biometry has to be done if you're planning surgery. Examination of the parents is very important. A broad systemic examination, of course, you're not a pediatrician, but just a broad outlook. I mean, what the child has, maybe some kind of dysmorphic features, and yes, a pediatrician review is also important. So coming to a first thing when the child comes is obviously you see the white reflex. The visual acuity assessment, the age-appropriate tools and techniques should be employed. Yes, the child has a cataract, so you might not be able to do all these things like optocataract nystagmus. Yes, resistance to occlusion could be there depending upon the density of the cataract. And all these other tests, it all depends how small the child, how young the child is, and how dense is the cataract. So I'll just be taking you through one of this little child who comes. Can I have the video? Yeah, yeah. So if you see this little child, he's not really focusing at the torchlight. He's having some roving eye movements, like nystagmoid movements, trying to see with the peripheral visual field if you see. So if you see, he's not really seeing the torchlight. He's looking up. He has some little nystagmus in his right gaze. Now he's trying to turn his head and see the torchlight. So this is very important. Now this could give you this could prognosticate the visual outcome. Because the child has a white cataract, we're not able to see the fundus. So he might be having a pale disc, or he might be having some other disorders. So this becomes a very important part of your examination, because it's a long process. The child would be coming to you for follow-up for a long period, and what you have to do is counsel the parents. The parents would think that, at least in this region, they think that it's like an adult cataract surgery. You operate on the cataract, and the child should have good vision. But no, this is not the case. The counseling and talking to the parents is very important in this case. So then comes your anterior segment examination. Of course, you have this young 3-month-old child who's in the lap of the mother, and it's not possible to put the child on the slit lamp. So a handheld slit lamp is very important in these cases. You could get a lot of information, what you would get on a routine slit lamp examination for an older child. So you should look for all these features like microcornea, corneal opacities, synecdoche, membranes, all the abnormalities like features of PFE, anterior PFE, any subluxation, a morphology of the cataract. If it's not white, probably you would be able to make out. Posterior segment examination, where the view allows you, yes, an indirect ophthalmoscopy examination is very good. And to rule out conditions such as PFE, you can have hemorrhages there, colobomas, as was very nicely shown by the previous speaker, optic disc and macular abnormalities. So it's just not the cataract. The visual outcome would depend basically on what's called the retina here. So the outcome is really dependent upon the condition of the retina, the condition of the optic nerve. Of course, distant direct ophthalmoscopy is one good thing in young children. You can just see if there's a good bright reflex, or is there some kind of an opacity in between. Ocular motility examination, very important. Unilateral cataracts who usually have a strabismus. They can have nystagmus, which is again a pointer towards a poor visual outcome. So retinoscopy, if it's a unilateral cataract, yes, the other eye retinoscopy has to be done, very important, because your planning of IOL implantation, the power what you're going to use will be dependent on the other eye. And clinical examination of the parents, you have to see if it's a familial cause. You could have subtle opacities in the parents, and they've never noticed it. So a dilated examination of the parents is also warranted, where you think that it's going to be a familial cause. Investigations, coming to the investigation, the B scan, where you don't have a view of the retina, probably for retinal detachments, PFEs, hemorrhages, all these would come up with the B scan. So just to know the integrity of the posterior segment, you need to do a B scan. And ultrasound biomicroscopy, again, maybe for anterior segment dysgenesis, or to assess the angle structures to rule out maybe subluxation. And sometimes, yes, if you have an AIOC, it's a good tool. Why? Because see this child. So what happens in this child has unilateral cataract. He was not showing because he has so much glare. The moment you put light, he closes his eye. So the other thing is do the AIOC where you don't have the glare. So it just takes a moment to take the pictures, and if you see there is a opacification in the lens. So this is just an ancillary tool, not to be done every time, because if you do a slit lamp examination, probably you'll get everything. Optical biometry is the best in older children, but in younger children, probably you would do an A scan and a manual keratometry to get the desired IOL power, and accordingly have your target refraction. So this is just a handheld keratometer, where when the child is sleeping, we could do the keratometry readings. And the axial length measurement, again, with the A scan, what you'll have to do, not very accurate as the IOL master, but yes, will give you a fairly good idea. So IOL power calculation, target your undercorrection, depending upon the age of the child, depending upon whether it's a unilateral or a bilateral cataract. If it's a bilateral cataract, all the investigations, which I'll be telling you in the next maybe 1 or 2 slides, that's it. In a unilateral cataract, as I told you, they would present as a white reflex, and most of them have strabismus. So probably, and all the investigations you would not require in a unilateral cataract, because most times the commonest cause is PFV. So for a bilateral cataract, you need this detailed systemic examination, multidisciplinary approach with the help of a pediatrician, and see for any dysmorphic features. A laboratory investigations for all these bilateral cataracts is is required to know the etiology of the cataract. So all these blood tests, what I've written, should be ordered depending upon what you think could be the cause in a child. So genetic testing, again, if it's familial, probably you know it's familial. We've examined the parents. But in other cases, sometimes the causes could be missed. It could be a harbinger of a serious disease later on. Of course, collaboration with the geneticist is crucial to interpret the results and for a comprehensive eye care. So I'd like to conclude here that the workup of pediatric cataract demands a meticulous and multidisciplinary approach. And pediatric ophthalmologists must integrate clinical, imaging, and genetic information to formulate an accurate diagnosis and tailored management plan. Thank you.
Thank you so much, Dr. Jaspreet. And I think we'll move to the next talk, which is by Dr. Sumita Agarkar, and she will be speaking on tips in pediatric cataract.
Good morning. How many of you have done a pediatric cataract? 1, 2, 3. Okay. Then please, this talk is not meant for you. So we see all types. Etiologies can be very different, but some part remains same, starting from a posterior lenticonus to a steroid-induced cataract. There is a whole potpourri of cases we see in our children basically here. So when you plan surgery, these are your steps which you must do: evaluation, anesthesia, and a lot of it Dr. Jaspreet has already covered. So I'm going to straight away jump to the surgical techniques. So these are your steps while doing surgery in this. So how do you do wound construction? You can use either a corneoscleral tunnel or a corneal tunnel. Both are perfectly acceptable, give equally good results. And if you are a beginner, probably scleral tunnel is recommended because it is definitely more forgiving, and you can put sutures. You don't have to remove sutures because it will be covered by conjunctiva. And if you are using a non-foldable lens, which sometimes in community settings we are forced to do, please definitely use the scleral tunnel instead of corneal, irrespective of the size of the wound, whether it is 2.2 or 3.2 or 4.5. You definitely need to be sutured in almost children up to 12 years of age. Even side entries may need suturing in infants and toddlers. So in the first, this is a corneoscleral wound you can see, and you can see you are going to make a little bit of a conjunctival opening, and that sometimes can be a problem for some of these children may need glaucoma surgeries later on. So less you touch the conjunctiva, it is better, but a small and clean conjunctival opening does not hamper any glaucoma surgery in future. Of course, now we have shifted to a clear corneal incisions. Like here you can see, it's you can see the depth of the tunnel is not much, so it is a little less forgiving compared to corneoscleral sutures, and but it's easier and one step. You don't need cautery, so definitely faster. Now coming to the anterior capsulotomy, which follows the wound construction, it is the key step in surgery, and children have elastic capsules and they have a tendency to extend is very high. A forceps, a microcapsular or a utrata forceps is probably easier than doing it with needle. Older children you can do needle also. Tearing forces should be always directed towards center, and it is important to regrasp the flap every 2 to 3 clock hours to maintain control over the size and shape of your rhexis, and always aim for a smaller size because you will end up with larger than what you anticipated. So in the capsular rhexis, the holy trinity of a good OVD instrument like a forceps and stains are absolutely indispensable. This cataract few years back, when stains were not available when I started my practice, would have been almost impossible. I would have used a light pipe to see using the illumination, and then also there was a good chance that I might have extended it. But now with, thanks to the staining, thanks to having a really stable anterior chamber, it is really not that difficult. And as you can see, my forces were, or tearing were always directed towards center. And allowing a microcapsular fossa also allows me to do the rhexis without doing a main tunnel, and you can do it through side entry through a small incision as I am doing here. Sometimes you will run into trouble with a fibrous capsule, and you can see here even the small entry you may have to do with actually a micro scissors, and you may have to actually go and cut the capsule into adequate shape. And yes, since one good thing about these kind of fibrous capsules are that tendency to run away as long as you stay in that fibrous area is very minimal, and you can definitely enlarge it after making these kind of radial cuts later on to make it little adequate size, and use vitrector to do slightly enlarge it. And this is as safe a bag as it can be. Newer technologies to do rhexis, you can do a precision pulse capsulotomy, which is an instrument where you can get a very regular and very predictable capsulotomy, but not that can be a little difficult if the anterior chamber is shallow and you have a really small eye. Femtolaser capsulotomy has been described, but again not possible under general anesthesia. But if a child is older, you could do it before you take the child into the theater for the rest of the surgery under anesthesia. Now, after lens aspiration, you have to manage the posterior capsule in the first sitting only, because VAO rates are close to 100%. And primary posterior capsulotomy, just as we do anterior vitrectomy, is the gold standard. But younger children may need anterior vitrectomy along with posterior capsulotomy to maintain a clear visual axis. Vitrectomy can be obviated by using either a special lens like a bag in the lens technique, or you can use a posterior optic capture also if you do not wish to do vitrectomy. Both these techniques compare well with primary posterior capsulotomy and anterior vitrectomy with preventing visual axis opacification. So again, the principles are same. You make a small opening and use a red reflex so that you only a retroillumination, because it allows you to visualize the flap really nicely against a red background. You don't need stainings because your red reflex acts like a stain here, and your forces, again, as you can see, 2 to 3 clock hours at a time, and grasp and regrasp till it is complete. Posterior capsulotomy is easier than anterior capsulotomy in almost every. Sometimes you may end up with posterior capsular dehiscence, as you can see here. So since it was a little anticipated, I have gone with the vitrector straight away to aspirate the lens also. And again, you can regularize this posterior capsular dehiscence and use a good OVD here to place the lens very comfortably in the bag without a risk of extension, if you just take away the edges where there is flaps to put it in the bag comfortably and fairly safely. Sometimes in rare situations, you may place the IOL first and then do a vitrectomy, like in this case. Okay, I think we don't have time for this. So this is the bag in the lens, and and there is another by Dr. Sukhija who spoke. Their group has published their reports with posterior capsulotomy, and I have borrowed this from their publication. The bag in the lens is where both the flaps of your are placed in a flap around, both the flaps of anterior and posterior capsule are placed in a groove which is made in the lens, as you can see here. And in posterior capsulotomy, after you have done the posterior capsulotomy, you push the optic behind the posterior capsulotomy, so that it kind of both anterior and posterior rhexis close over each other, and that also almost prevents any kind of PCO. Now lenses can be anything, IOLs, any of these lenses you can use. PMMA lenses are perfectly safe. 3-piece, single-piece acrylic foldables and single-piece foldable lenses have really changed the game. Bag in the lens is not available yet in India, and Similarly, for iris fixated lenses and artisan IOLs, we have little less evidence that they work well in children, but they are increasingly being used in some children with poor capsular support. So they were, as I said, they were game changers, and they allow a closed chamber, fairly closed chamber without leak, and also allows us to place the lens really safely into bag through a smaller incisions. And they are very useful in simple as well as complicated situations, as there is less manipulation which is required, and inflammation has almost gone down to zero with these lenses. So IOLs have also led to more questions: what age you should implant, what is your target refraction, and what is the IOL power calculation. So 1 year older is IOL is the standard of care, but rest in 2024 it's more of an anatomical decision and not so much the age. I would still consider IOL implantation in any eye with corneal diameter of at least 10.5 millimeter and axial length of 18 and no ocular comorbidities. There are ifs and buts in that, but when it comes to under 1 year of age, these are the criteria which I use. If you are in doubt, if your surgical skills are not adequate, a good aphakia is always comparable to pseudophakia in infants. You can always put IOL later, provided you do a clean surgery. In some situations like JRA-induced uveitis, probably pseudophakia is still better than pseudophakia. We have sorted out the age, but we still don't know what to put, and this is fraught with errors in younger children, especially if you are going to do a DBR in under general anesthesia. Always remember, smaller eyes, your smallest error will get magnified, and you will get a much more larger error in your post-operative refraction, even if you have got a small error in your axial length calculation. There are a lot of conflicting data published in looking at different formulas, and still there is no consensus that this formula is better than that. We have done some work in Indian eyes on Barrett's universal formula, and we found that comparable to a standard older formula like SRK2 or SRK-T. What can go wrong? These are all complications. Some of them, like glaucoma and retinal detachment, can occur many years later. Rest are all between intermittent and immediate and intermittent period. Visual rehabilitation is the most important part of surgery. No surgery is successful unless you do this: refraction and prescription of glasses as early as in first week. I give it routinely on 4th day, appropriate occlusion if required, and follow-up. Follow-up is how meticulously you follow up is the measure or metric by which you should measure your success. And surgery is just a very, very small and very easy step on a very, very long road. Schedule of follow-up depends on age and visual status, but up to 3 years, child should be seen every 4 months, every 6 months till 10 years, and once in a year all their lives. What follow-up entails? It entails refraction and vision check, because VAO can undo your beautifully done surgery within few days. Intraocular pressure on every follow-up visit, and a dilated fundus examination on every visit, including a very careful look at the disc. What lies ahead? We are looking for better biometry calculation, better designed IOLs, and we need to be prepared for long-term complications, which we still are not dealing with. When these children will become 45 and above, there will be probably a slew of other things which may come, which we don't know yet. Like, this is my 20-year-old follow-up. Vision is still maintained, but you can see the lens is looking dull. It is a good acrylic foldable lens, but I know I may have to replace it in another 10 years. God only knows. Thank you for your attention.
Thank you, Dr. Sushmita, for such a nice talk. Now I would invite for the keynote address, Dr. John Peter Sonte. He has come all the way from Denmark to present his talk on torsional diplopia, assessment and treatment options, including the patient perspective. And he has a specific interest in pediatric ophthalmology, strabismus, neuro ophthalmology, oculoplasty, and trauma. So, Dr. John Peter Sonte, for the talk, please.
Thank you for the nice introduction, and thank you for letting me come to wonderful India again to share some of our thoughts on what we work on. Could I have my slides, please? So I know an Indian love song. I will not sing it for you now, maybe another occasion.
Can we have his slides, please?
I prefer the slides. So while we wait for the slides, what I want to share with you with this in this talk is how patient sees torsion. See if they have torsion diplopia, how does it affect them, and what should we listen to try to understand what's going on. So I've tried to make some TED Talk. Yeah, we'll make it. I'll draw some figures on the wall somewhere. But torsion, I think one of my residents, very talented resident, he missed the torsion. The patient had perfect vision, had some complaints going down, and everything was fine. So why should we do anything with this case? And the patient had torsion and suffered from that. If it's better with the program to change the row of speakers, I can take this later during the day, whatever works with you.
Audiovisual guys, can we have a talk, please?
I can use my stick directly on this computer. Does it work?
So audiovisual guys probably have a little bit of torsion. Finding it difficult to...
I'm sorry?
I mean, the guys are having torsion.
Yeah, something's torted somewhere.
Not able to sort it out.
It's fine, no problem. So I traveled to India in 1993 as a medical student and stayed 3 months in a hospital in South India, which completely changed my way of thinking. I was thinking to be a cardiologist at that time. There was a very, very famous cardiologist working at that hospital, so I wanted to visit him. But at that same hospital, they also had an ophthalmologist which did cataract surgery, and she was turning blind people into seeing. And that changed my career, so I wanted to be an ophthalmologist as well. So India changed my life career actually in ophthalmology, which I'm very thankful for.
He has a pen drive. He can use this laptop.
Should I take it from this? Oh, something's happening.
Can you please come here and help him put his...
Shall I come to your place? I can give the talk from there. Oh, this looks great. So we can run from now? Okay. So can I, when I want to change the slides, do I use the screen here? Yeah, here. Okay, now go. I have a interest conflict, so it's not interesting for us. So how do the people experience torsion? So this is India this morning, and if you have 5 degrees of torsion, this is what you may experience. This is 10 degrees, and this is 15 degrees. So 15 degrees of torsion is quite disabling for all of us. So how can we treat this? And this is the patient I mentioned before, fell on the bike in Copenhagen. She was drunk, and she had a bad brain injury. Her eye workup was normal, and we saw her 6 weeks after the trauma in our clinic. She was ortho in primary, but a down gaze ET. And she has a left hyper on right gaze and right hyper on left gaze. So this is, and she also had excyclotorsion, worse as down gaze. And this is what's going on. She has excyclotropia. So the eyes are excyclotropic due to bilateral fourth. So we wait, we see what's going on. We wait 9 months, and she is still symptomatic. Down gaze is a problem. And we wait 16 months to see if this goes away. We ask her, how are you doing? Well, she says, I'm better now, but at down gaze I have big problems. Reading is a problem. walking, making food. She cuts her hands when she's cooking. And this is why she doesn't drive a car anymore. So her life, the world is twisted for her. And when she reads on top of the screen, everything is fine. When she looks down, this happens. So she has a torsion on down gaze. And we tried her, can't you show us how this works? So we took these 2 pieces of plastic, put them on top of this other. This is one each eye, each figure. And I asked her, can you show us how is your world, what do you see? So now she's showing us her double, and it's twisted and it's vertical and horizontal deviated. So when you have torsion diplopia, there are many reasons for this, we know this. So we want to take care of this problem, and instead of having pure torsion, you can even have a situation where you have a unilateral fourth, and to compensate for this, you tilt your head. And if you have a unilateral fourth, you will actually have both torsion and vertical misalignment. So what do the patient complain about? They complain about blur, so this is what they can experience. Things are a little bit blurry. It may be difficult for them to explain for us how does the world look for them. And they have all kinds of problems related to torsion. We can try to assess this in many ways. Maybe the synoptophore is the golden standard for most of us, but other tests out there are very useful. And especially the screens where you can test torsion in different directions are of value. So what about treatment? What can we do? We can patch them. We can do the surgery. And when we do the surgery, we want to use a microscope. And the microscope makes it easier to find these small details, and we use small tendon hooks. If you want to use adjustable sutures, opening away from limbus is nice because the sutures won't pop out in the opening for you. And if you have a surgery on superior oblique, remember there's a little tendon between the superior rectus and superior oblique. You cut it, and the barbier retractor gives good overview for you. Cutting the tendon. What suture should we use? Well, we usually go for Vicryl 6 sutures when we suture to the eye, but if it's not attached to the eye, we use a non-absorbable suture. And if you want to take care of excyclotropia, what to do to take care of this? You can tuck it. And when you tuck the tendon to avoid inducing a Brown, you need to do the repeat force reduction testing to see if you have created a Brown syndrome. Harada Ito may actually produce in hypotropia, so if you split the tendon posteriorly, you will take care of that. And many ways to do this technique are discussed, and I know Eric Boughton will discuss this a little bit later, so I'll just skip a few of these slides. We know that when we tighten the superior oblique, this will stretch, it will unwind, and during the first week, it usually unwinds up to we found up to 10 degrees for a week. And Jonathan Holmes found that if you do a unilateral Harada-Ito, you should overcorrect it 7 degrees because that's what the unwinding you're expecting. And during the surgery, you can actually put some, drawings on the table, and then you can, when you measure, you can put the instrument aligned with the drawings on the draping, and then when you have the blue dots on the cornea at 6 and 12, you can see how much torsion do you induce during the surgery. So adjustable sutures will help you to do what you want to do, to dare what you want to do. So we tighten the superior oblique, and we can unwind or change the tightness with adjustable sutures, which are hit on the conjunctiva afterwards. So let's go back to our bike accident before. She had a double bilateral Harada-Ito performed. This was before surgery, big excyclotropia down gaze. And after surgery, these were taken care of. And we asked her, how does your double look like now? So up gaze, there is a little overcorrection, so he has incyclo, but in primary gaze, pictures are aligned, and at down gaze, things are also working well. So when she wants to read important text, when she reads down this text, everything is fine. Other surgeries for excyclotropia, we can work on the inferior oblique. We can make that an intortor. And the group from Delhi has looked at what happens if you make the inferior oblique, you put it nasally. If you work on the inferior oblique, this will take care of maybe 3 to 6 degrees of torsion if you put it temporally, but if you put it nasally, you will have a big effect to correct the excyclotorsion. The group in Japan has looked at a lot of inferior rectus nasal transposition to take care of torsion, and they found that if you do this unilateral, it takes care of 6 degrees, and in bilateral, it takes care of 11 degrees. And if you have encyclotropia, which is the last thing I want to discuss with you, if the tendon is too tight, like in Brown syndrome, encyclotropia, you want to avoid the double day experience, then you can, after the force duction testing, when you press the eye into the orbit, and excyclo and encyclo rotate the eye, then we put the numbers on the wall and the whiteboard, and we cut the tendon. And just a few notes about this. We use this nice little tool which holds this tendon for us. And we know that this is a quite an unpredictable procedure, so we have developed a suture where I just want to skip you to the pictures here. We have combined sutures with a chicken suture and this short tag noose suture. And if you do that, you can have an adjustable super oblique suture, which is actually adjustable. And this is how it looks in real life. It's a Merslin suture with a vitral noose, and this will allow you to adjust the suture up to a week after surgery. So this is a case from before. Has a right hyper and right gaze. And we make a 4 millimeters chicken suture. This was not enough, so we increased this to 8. And after last adjustment, he is ortho and side gaze, and head tilt is corrected as well. And we found that the torsion effect from the spacer effect is up to 5 degrees per millimeter spacer. It depends upon how many millimeters you prolong it. So in conclusion, torsion, the symptoms are invalidating for the patients. The assessment can be done by many different techniques to opt for, but we need to help these patients by surgery. Thank you.
Thank you.
One last comment. I'm sorry. So yes. So this is just. I'll just share one thing with you, because all of us who do strabismus surgery, we might have nightmares when we do the wrong surgery on the correct muscle, or vice versa. So if you have a planner in your OR and write the plan in the room, everybody can see it. You double check it through this several times. You will be sure you won't have nightmares about your own surgeries. Thank you.
Thank you, Dr. Peter Svante, for such a nice talk and making us aware how the patients feel in case of diplopia they have. And thank you, everyone. Thank you, all the speakers, for this session. And I would invite the next chairpersons for this next session to come on the dais, please.